So I just want to finish up by talking a little bit about the management of celiac disease, and in particular some of the management things that we need to think about beyond the gluten-free diet. So sort of in outline, the management is, the mainstay of treatment still is the lifelong gluten-free diet. It does require dietitian guidance. And I think that's something that I think most people are good about referring patients with newly diagnosed celiac disease to dietitians. But that study that I talked about this morning that was done a couple of years back by the dietetic student in Dunedin of almost 1,000 celiac patients, about 15% of them who were people with diagnosed celiac disease had never seen a dietitian. So when diet is your core management, that's risky at least. It needs dietitian guidance. It has to be gluten-free, not low gluten, and we've already talked about that. And it may require supplementation with vitamin D and calcium and iron as well early on. But it's a chronic condition, so there are other priorities that we need to think about when we're managing our celiac patients. We need to think about the potential complications and minimise the risk of those. And we need to be aware of the risks of associated conditions and look for those associated conditions if that's indicated by symptoms from the patient. So things that we need to consider. The gluten-free diet is expensive. Even though there are more and more gluten-free products available on the market, they are still more expensive. And I did a little recce round the supermarket in Dunedin a couple of months ago just to compare some gluten-containing products with gluten-free products. And some of the core sort of dietary things like bread, a loaf of gluten-free bread is about 6 or 7 times more expensive than sort of just cheap budget bread. And sometimes higher. So it is expensive. It's a cunning marketing ploy to stick a gluten-free label on food products. I did in Australia at one stage see gluten-free milk being advertised with gluten-free, and I thought, oh my God, what does that say about the rest of our milk if this milk is gluten-free? As Sarah talked about earlier, sort of people being able to read labels and make decisions for themselves about what's safe and what is not safe is helpful. You can consider patients' eligibilities for the disability allowance and for the child disability allowance, and Coeliac New Zealand will help people with applications for those things. The disability allowance, there are definitely people who are on community services card and who would otherwise be eligible for a disability allowance. They can get assistance through that for buying gluten-free foods. Certainly with the young children with celiac disease, they are entitled to a child disability allowance with that. Now that changes from time to time, the sort of criteria around disability allowances, but Coeliac New Zealand have done a lot of work negotiating around disability allowances, and they're a good source of information, or a good port of call for people who are wanting to do this for the first time, for if they've got a newly diagnosed child in particular. It is still, and then there's the special authority number for subsidised prescriptions. So probably around about 50% of people with celiac disease now don't bother with the special authority number because the range of gluten-free products that they can buy is so broad, but it is actually still worth pursuing for some people, particularly in the South Island and areas that have access to the hospital to home scheme, which is run by a company called Crombie and Price. That's a really comprehensive system for people with celiac disease, but the number of products that you can access or that you can get your subsidies for is quite narrow, and that's not being expanded as time goes by. Yes.
Do you need that with the disability allowance as well?
No. Not that I'm aware of. No. So to access the special authority at the moment, you do need to have biopsy-proven disease. It can be either biopsy-proven celiac disease or biopsy-proven dermatitis herpetiformis. But it's mostly flour and pasta that you can access on prescription. Now, some people actually go through a lot of gluten-free flour because they still do a lot of their own baking and stuff, so it can be useful for them to get that subsidised. But the subsidy hasn't increased as the prices of those products has increased. But yeah, for some people it's still worth doing. Yep.
Sorry, potentially a stupid question. I haven't ever done this before, do they literally take a prescription for flour to the pharmacy?
Yep.
And then the pharmacy dispenses it, the
Yep.
pharmacy stocks? Okay.
Yeah. I think sometimes I think that there are probably some community pharmacies who don't have it in stock all of the time, but if they've got patients who they know are celiac, and then they will keep some in stock. And you can get bulk, you can prescribe it, and usually patients know how much they need, and so they can get like boxes worth of pasta and things. So it's certainly something to think about, and definitely it's definitely worth talking about it with the patient to see if they want to bother with it. Whether or not, if we move towards, as certainly the Starship team are looking at trying to move towards confirming the diagnosis of celiac disease in children without biopsy, whether or not, if that shift is made and accepted, whether or not there will be revised criteria for being able to access the special authority number I don't think has been canvassed yet. But there would need to be clear criteria for that the diagnosis had been made on. Otherwise, potentially anyone who's on a gluten-free diet might be wanting to do this. Okay, other things to consider. Changing to a gluten-free diet is actually a big deal for people. Socially and practically, it's a big deal. And I can speak from personal experience on this. I didn't quite appreciate how big a deal it was when I was first diagnosed with celiac disease until I found myself standing in the supermarket aisle one evening before my younger daughter was about to turn 2, I think, and I found myself looking at a packet of gluten-free icing sugar, and I started crying because I thought, oh my God, I can have the same cake that my baby can have for her birthday. I thought, ooh, gosh, this was more significant than I thought it was. And so it is important. Food is it's so integral to our social interactions. So much of the social currency that we have with people is based around food. And if people are separated out because of a food that they can or can't, or that they can't eat, then that does have an impact on people. And I think we need to kind of bear that in mind when we're talking to our patients about how they are managing the gluten-free diet. How are they managing the impact that it's having on them in their day-to-day lives, the work shouts, the after-work thing, the birthday parties, and it's particularly important for children who don't want to be different. Adolescent kids especially don't want to be the different kid who can't eat the pizza when everybody's having the pizza and movie night. And so we need to be, cognizant of that. As Sarah's already talked about, food labelling is complicated to interpret often. The writing is often really tiny, so I'm finding now that I'm going to have to get my reading glasses out to read the labels. So someone did a study in the States quite a number of years ago now. They looked at the extra time that it required to go around the supermarket, and it's several hours cumulatively per month of shopping just to read labels for food. So it's something. So if you've got patients for whom literacy is an issue, then they're actually going to struggle with reading labels. Contamination of foods is common. This is the double-edged sword of the gluten-free diet being more popular, because you get people who go into cafes and say, oh yes, I'll have the gluten-free thing please because I'm on a gluten-free diet, and then they see the chocolate brownie that's not gluten-free. Oh, that looks really good. Oh, actually no, I'll have that one instead. Oh, it doesn't really matter. And the staff working in the cafes and all the rest of it often hear that, so they don't appreciate that. For some people it's not a choice, it's that they don't take the same degree of care in terms of the cross-contamination and things. So if I go into a cafe and I can see that the gluten-free food is separate from all of the other crummy, slicey, biscuity things in the cabinet, that there's a separate pair of tongs that they'll use to get my piece of slice out of the cabinet or whatever, then I'm much more confident. If I don't see that, or they don't know what I'm talking about, I just won't have it. I'll just have my cup of coffee. It's my justification for having milky, sugary coffee, because I don't have cake often. So contamination of foods is common. It happens in the home. So people with celiac disease need to have their own pot of jam, their own pot of marmalade, their own pot of margarine, all of those things, because if I've swiped my toast and you swipe your toast, then there's cross-contamination with crumbs and stuff. And they will get that kind of information from a dietitian usually, actually. And so that's where it's that extra bit of information around the diet that's important, that the dietitians are particularly skilled at advising patients on. And also Celiac New Zealand is very, and there are local groups usually for Celiac New Zealand, and I would certainly recommend that for when patients are newly diagnosed, that they are put in touch with Celiac New Zealand, because they have invented a number of wheels to help make the process easier. There's no sense having every patient reinventing them. Some medications do contain gluten. Apofolic acid is the one that I'm still aware of. Codalgin, which we used to have, had gluten in it, but we don't have Codalgin in that brand anymore, but we do have apofolic acid, which is tricky if you're trying to replace folate in someone who has celiac disease. It is a very small number of medications that will have gluten in them, and it's a very tiny amount of gluten in the medications. Pharmacists are probably the best source of information about that. So if you've got a patient with newly diagnosed celiac disease and they are on a swag of medications as well, then it's worth checking in, either getting the patient to check in with their pharmacist about the medications to make sure that they are also gluten-free, but the vast majority are. So there are some people who, the longer you are gluten-free, the more sensitive you become to when you are exposed to it, often is the case. But it's more the cumulative effect. So if a person with celiac disease had a swipe of margarine that had a few crumbs of someone else's toast in it, that one episode might not cause them a problem. But if that happened every day and there was constant, plus they went to a cafe and had something that was also contaminated with crumbs, plus, so it's the cumulative effect to get them to a threshold dose of gluten. It equates to the sort of 20 parts per million that Sarah talked about as being debated in the international literature as a safe threshold. There is a difference between symptoms and damage to the gut as well, and that's the problem, is we can't tell. So a person who's been on a mostly gluten-free diet for a long period of time may not get symptoms, but may still have will still have damage happening in their gut because they're tolerating it at a symptomatic level. Does that make sense? So I would recommend that patients join Celiac New Zealand at least when they are first diagnosed. They've got loads of resources. They can hire out or just lend recipe books. Some local branches have like bread making machines and things that people can hire for a bit to get a feel for how whether they can make their own bread. They do a lot in lots of regions. Members of Celiac New Zealand will do supermarket tours with newly diagnosed people to show them where the gluten-free products are, go through the label reading process. Did you know that all of these products are also gluten-free? That kind of stuff. So I think it's well worth doing it. So complications of celiac disease. Osteoporosis is a complication of celiac disease. A number of people, I've certainly had 3 or 4 patients who actually that's how we diagnosed them, was that they had osteoporosis at an early age or unexpectedly severe osteoporosis. The Auckland gastroenterologists a year or 2 ago did a survey or a study where all of their newly diagnosed celiacs, they also did a DEXA scan on them to see what the incidence of osteoporosis was. And it actually wasn't any greater than they expected for the sort of age-mapped non-celiac population. So it's there's a bit of sort of swinging backwards and forwards about the relationship between celiac disease and osteoporosis, but it seems likely that the longer people have had undiagnosed celiac disease, the more likely they are to have osteoporosis. And it would seem that men with celiac disease are more prone to having osteoporosis. And again, that's possibly to do with the fact that they've gone on for longer before being diagnosed, so they've had longer for impaired calcium and vitamin D absorption. So the specific malignancy that we worry about is enteropathy-associated T-cell lymphoma. The people who get that as a consequence of celiac disease are those generally, it's a variant of refractory celiac disease. The proportion of people with celiac disease who go on to get refractory celiac disease is, do you know the number, John? But it's the people who get refractory celiac disease is about, I think it's around 1 or 2%, is it, of people with celiac disease, so it's quite low. And of them, depending on the type of refractory celiac disease, 5 to 10% can get this enteropathy. So it is really small. So enteropathy-associated T-cell lymphoma is vanishingly rare, and amongst people with untreated celiac disease, it's still very rare. So it moves from vanishingly rare to very rare. But I can't actually, I could probably, I can probably give you the numbers, but not off the top of my head, and it's not in my slides.
Otherwise kind of okay, what are we trying to avoid?
How do we counsel her to be better?
It's the overall.
If I'm miserable, having to have this diet, and she's 62.
It's the overall benefit to her health. So it's not just the risk of GI malignancy. It's also actually the risk of other autoimmune disease. That's more likely. Is developing a second or third autoimmune disease, which will also bring with it morbidity. There is this concern about hyposplenism and increased mortality from infection, and again, there's been a big meta-analysis done recently which does sort of support the fact that people do die from infections that we wouldn't expect them to die from if they've got hyposplenism as a consequence of their celiac disease. But it is tricky. I agree. It is tricky to try and sort of weight that for a patient so that they take it seriously if they don't have symptoms.
And these complications would all be more likely in someone that was not adhering to the
Yes, absolutely. Yeah. So the take-home message from this is adhering to the diet is the thing that's going to protect you from these complications. Now, some people will be fully adherent to the diet and still get these complications, just because that's sod's law that somebody will. But the best way that you can protect yourself from these complications is by adhering to the gluten-free diet. There is debate about this business of 5-yearly pneumococcal vaccinations. The American guidelines, I think, are sort of leaning towards it. One of the sets of guidelines is sort of leaning towards suggesting that people should have pneumococcal vaccination, and the other guidelines don't go there at all. Probably the middle ground is to assess people for their splenic function, which you can do you can ask the lab to look at their full blood count to see if there's evidence of hyposplenism, and they would be the group to be thinking about pneumococcal vaccinations, which is not subsidised. Complications of the diet. Sarah mentioned this as well. It's low fibre, high saturated fat, high sugar, low B vitamins. So all the stuff in the women's magazines about how fantastic gluten-free diet is not strictly true. The other thing is that we see a lot of, if you go to Celiac Society meetings, you might find that quite a few people at the Celiac Society meetings are actually overweight. And the reason for that is because a lot of these people have never had to worry about their weight through their lives because they weren't absorbing a lot of the nutrition that they were eating, and you fix that problem and suddenly they're absorbing the food that they're eating and they actually put on weight, and it's quite an adjustment to have to make to actually sort of monitor your calorific intake. If you're a person who's never had to, you've always struggled to keep the weight on, to change that whole milieu because your gut's now functioning, and so that is something. And their cholesterol levels go up a bit too because they're actually absorbing things better as well. So it's something to bear in mind. So I surveyed New Zealand gastroenterologists a couple of years back now, and one of the things that they are almost unanimous on was that part of our follow-up for people with celiac disease in the first 12 months should include abnormal test monitoring. So we should definitely be retesting them to make sure that the iron deficiency is resolved. If we've checked for anything else like B12, folate, some people do zinc levels, calcium levels, vitamin D, all of those things, that we should make sure that anything that was abnormal has come back to normal. They're divided on some of these other things, but mostly in favour of DEXA scans. Definitely we should be reviewing to make sure their symptoms have got better on the gluten-free diet. Follow-up testing of the TTG test. This is a little bit controversial. It takes a long time to go back to normal. And actually it takes a long time for the gut to heal, and so the whole issue of follow-up biopsies is also a bit controversial. But a person who is adherent to the gluten-free diet, it may take up to 2 years for their gut to fully recover. So if you go biopsying them, re-biopsying them inside 2 years, you may actually still find that they've got inflammation or evidence of villus atrophy, and you don't know whether that's because they're not being compliant or because they actually just haven't recovered yet. The TTG monitoring, again, it's less a marker of healing of the gut. It's probably a better marker though of dietary indiscretions. If it has come back to normal and then it goes up again, then that's the most likely cause of a rise in TTG. Is dietary indiscretion, either consciously or unconsciously. So some people would say do the TTG every year. Some people would say do it to see that it's coming back down to normal, and then only do it if you've got reason to be concerned that the person is not adhering to the diet, or that they've got a re-emergence of symptoms and you want to know if that's a possible explanation for it. Longer term management, regular reinforcement of the gluten-free diet is the other thing, and I think this is where we as GPs can be possibly a little bit, and practice nursing staff actually can be a little bit more proactive with our patients, is actually our celiac patients asking them from time to time, how's it going on that gluten-free diet? You realise it's important, you know that it's important, just checking, how you're going with that. And there have been studies that show that just the fact of asking about it by a health professional kind of increase, it sort of must be important. If the doctor or the nurse is asking me about it, it must be important. There's a little bit of evidence that that's helpful. So I think we should be doing that, and we should be reinforcing it. Again, this was, the specialist colleagues were pretty lukewarm about the thought of the importance of flu vaccinations and pneumococcal vaccinations, and I think most people would suggest that we should be giving flu vaccinations to any of our patients who meet the criteria for flu vaccinations. Celiac disease would be a criteria for flu vaccinations, and the jury is out on pneumococcal vaccinations. The other issue I just want to touch on briefly is whether or not we should be doing an annual review for our patients with celiac disease, much like we do diabetic reviews and all of that jazz. The guidelines are all leaning towards it, that we should be doing an annual review aimed specifically at celiac disease amongst our celiac patients. So I've just listed there the reasons for and against. So it is an opportunity for early identification of problems, attest to the significance of the condition, may increase adherence to the gluten-free diet. The cons, there is low to moderate quality evidence that in support of this, despite the fact that they're quite strong recommendations that the guidelines groups are making. So the evidence is, there is a cost at the moment to the patient for them to come back and have a review. There's a cost to the practitioner in terms of time and capacity and things. There is patient resistance to it if they are otherwise well. And it's not actually very clear what we would be including in our annual review of patients. So I think at the moment we're at the place where we should be thinking about it, and we should be thinking about our celiac patients, thinking, is that a person that I need to actually talk to about their celiac disease and review them? If I was going to review them, so we were divided in the survey I did of GPs. So the biggest group thought it was probably necessary, nearly 45% of us. Less than 25% thought it was definitely necessary. So there's quite a crowd of us who are sort of neutral or think it's probably unnecessary. The reasons that people were giving for that were some of those things that I listed: cost, access, how do I fit this into all of the other things that I'm supposed to be doing, what's the benefit to the patient, how do I convince my patient this is a good idea, all of those things. And I don't have the answers on those yet. We don't have the answers on those things yet. And what would you do? And gastroenterologists, they thought it was, again, there wasn't they were divided, but more than 50% thought it was probably important to do an annual review. When I asked who should be doing the annual review, have I got that slide? Oh yeah. So GPs think, 78% of GPs think GPs should be doing the annual review of celiac disease. 73% of gastroenterologists think that GPs should be doing their annual review of celiac disease. Not surprisingly, I suppose, fewer GPs thought gastroenterologists needed to do it. Gastroenterologists had a slightly higher threshold for them being the ones to do the review. Dietitians, practice nurses and other, which included people who responded, or it could be any one of the above if they had an interest or knew what they were reviewing and things. So there is a mood or a feeling towards it. It's just how we would implement this in a way that was practical and actually delivered results that were meaningful. So an approach to management, which I think, which I've sort of adapted from the American College guidelines and the British guidelines and the NICE guidelines, and sort of pulled together, is that it should be a stepped approach to our patients with celiac disease. So at diagnosis, we need to make sure they've seen a dietitian. We need to investigate them and treat their micronutrient deficiencies. We need to consider bone mineral density, and that would be a patient-by-patient kind of decision. And we should actually at least be telling them about celiac disease, Celiac New Zealand, if not encouraging them to join Celiac New Zealand. We should see them between 3 and 6 months afterwards, see how they're getting on with the diet. And that would be a time, I think early in that first year, it's certainly appropriate to do the antibodies because you want to see them falling. They may not come back to normal, but you do want to see them falling in that first few months or first year after diagnosis. At that point, we should also be recommending screening of their first degree relatives. And that's certainly a recommendation in the guidelines, that we should be making that recommendation to our patients. And then 12 months, we should again look at symptoms, adherence, complications. For children, we should be keeping tabs on their height and weight. And we should be at least thinking about the vaccinations that we're offering our adult patients, and certainly paediatric patients should be having their regular vaccinations. Any questions about any of this?
You mentioned a couple of times refractory
Yes.
disease. What is that?
So refractory celiac disease needs to be, it's a biopsy confirmed condition, and it is where people have ongoing villus atrophy despite the fact that you are absolutely confident that they are adhering to a gluten-free diet. And so the first step that should happen, actually that's my next slide I think, if the patient is not recovering, the first thing you need to do is check their adherence to the diet. And I would suggest in a situation, if you've got someone who's not getting better in the way that you would expect them to, refer them to a dietitian to review that more carefully. And it can be intentional or unintentional. So I've certainly had colleagues, when we've been talking about this at different times, saying that they had a patient, they couldn't work out why this person wasn't recovering until they finally, and the patient's, it was, are you on a gluten-free diet? Oh, yes. Oh, except I do have a treat on Sundays. And so it didn't count, the treat on Sundays somehow didn't count in the mind of the patient, but it certainly counted in terms of what was happening in their gut. So refractory celiac disease requires certainty as much as possible that they are adhering to the diet, and they need to be referred to a gastroenterologist who'll do a repeat biopsy, and there are certain criteria on biopsy that they will look for. There are a couple of centres in the UK that have implemented what they call a super strict gluten-free diet, and they have managed to get a cohort of their patients with what they thought was refractory celiac disease to recover on the super strict gluten-free diet. And so they certainly excluded oats, and there were a few other products that they sort of excluded completely from the diet and had them on quite a restrictive diet, and managed to heal the gut with that. The other thing is, occasionally we do get the diagnosis wrong. That you can get what look like histological changes that are consistent with celiac disease, and it's not celiac disease. So autoimmune enteropathy is a thing that's not celiac disease, and it won't respond to a gluten-free diet. So there may be alternative diagnoses. And I think that was my last slide. Good.